we are slowly moving into understanding and learning the various aspects which are essential in palliative care. So, to start off, one of the important things, or what is that you will have to deal to a very great extent when you see patients in palliative care, is pain. So, for pain as such itself, you will have few sessions. To start off, you should know what is the basic of it. So, for that, we have an eminent person to take you through that. So, with that, I welcome Dr. Smriti Khanna, who is a consultant pain and palliative care physician at Hinduja Hospital and Medical Research Center. And prior to that, she has been working as consultant in Bhai Jarbal Wadia Hospital for Children in Mumbai. And she has had extensive pediatric hemato-oncology experience for 5 years, for 2 years, and in working in general palliative medicine for about 5 years. Not only clinical experience, she has been a faculty at various palliative care teaching programs, importantly in pediatric palliative care at 2 world cancer centers. And also she is an important member at the Pediatric Palliative Care Fellowship for South Asia. And she is also an important person in International Neuropalliative Care Fellowship courses. So you've got someone who has got both clinical and academic accreditation to take you all through this session. With that, I hand over to you to Dr. Smriti Khanna.
Thank you, Madam, for that introduction. And I thank a lot. I would also like to thank Pallium India for inviting me to take on this session. And I would also like to thank all the participants who have felt the interest in palliative care, which is something which is very important for a lot of, which is very important for India. And I get very excited whenever I see a lot of people having interest in wanting to practice palliative care in all the centers that they are at, because this is an unmet need still, and palliative care is still in its nascency in many centers all over India. So I will now like to take you through the basics of pain and introduction to pain, if you will. If you just give me a minute, I will share my screen and then we can start. Okay. Can everyone see the screen?
Yes, ma'am. It is visible.
Okay, so we are now starting with an introduction to pain. This is my introduction. Madam has already given a lot of it, and so I'm not going to lose too much time on this slide. Let's start with our session objectives. What we would like to start with, pain is actually one of the most important symptoms that we will deal with as we see patients who need palliative care. And so we are going to go step by step on an introduction to pain. So we start with the definition of pain, some revision and some understanding of the pain pathophysiology. I know a lot of us must have read about this in MBBS and then not bothered to think about it at all. And so it must be a while. And so we will just revise a little bit. Then the classification of pain, what are the different types of pain out there? Then how do you assess pain? And I'm also going to go a bit into the management, in which I will be talking about the WHO analgesic ladder, what are some of the drugs that we use to treat pain, and a little bit about opioids. I understand that you are going to have an entire session or a couple of sessions on opioids. And so this is just going to be an overview on the use of opioids, and I'm not going to go in depth in it. So to start with, what is pain? The International Association for the Study of Pain has recently changed the definition in 2023. And what they say now is that pain is an unpleasant sensory and emotional experience which is associated with actual or potential tissue damage or described in terms of such damage. So you understand here that there is a sensory component as well as an emotional component. So it's not just a physical experience. There is actual or potential tissue damage. So this speaks with basically to our body's response to any kind of perceived threat, real or perceived. And so these are all the components that form part of the definition of pain. Some other things that we also believe in palliative care is pain is what the patient says hurts when he or she says it does. And the most important takeaway that I want you to have from this slide is that you have to believe the patient regarding his or her pain. Now, the other thing is that pain is an emotional experience, and physical pain can be made worse by psychological, social, and spiritual factors. And we will come to some of these in the slides to follow. Okay, some more nuggets about pain. What we must understand is that it's not inevitable. And this is especially true in patients with cancer, because there is a common misconception that if you have cancer, you will have pain, and it's not going to be pain that. The other nugget that I want to share is that over 80% of chronic pain also can be controlled with inexpensive oral drugs. Pain needs proper assessment and systematic use of analgesics. We cannot go about it in a haphazard way. And access to pain is a fundamental right. We know by now that pain is the fifth vital sign. So how often or how frequent is pain going to be in patients that we see? It's a major symptom in 70% of our patients with advanced cancer and in 60% of patients with non-malignant diseases. So whether you are seeing whether you are practicing malignancies, or even if you are seeing non-malignant patients, you can be rest assured that pain is a symptom that you will encounter frequently. Now, there is another important concept in palliative care, which is the concept of total pain. And I think some of us might have studied the biopsychosocial model of pain in our undergraduate curriculum. And that says that there are multiple components to the experience of pain. So this takes it a little bit further and says that total pain means the physical component, the psychological component, the social component, and also the spiritual component. So the physical component means the actual physical perception of pain. And along with it, it could be an undesirable effect of treatment. Along with it, there could be insomnia, there could be chronic fatigue, there could be other symptoms going on along with it. And then we have the psychological aspect of pain. It can often be accompanied by anger, and there is sometimes disfigurement, especially in patients with head and neck cancers. There is the fear of pain. A lot of patients are worried about the next bout of pain and when it is going to come, and may not move because of that. There is the fear of death associated with pain. Pain is a symptom that can very strongly take hold of our emotions, and we are not able to think rationally at that time. And then there is the feeling of helplessness, that this is just not going away. It keeps coming back, and it looks like it's going to keep coming back. And then you have the social aspect of pain, wherein pain is obviously secondary to some kind of underlying disease. And so you are worried about that. So you're worried about your family. The patient is worried about their loss of job, loss of income. Sometimes they are the primary earning members, their loss of social position, and their loss of position in the family. Many a times, what we do or what function we do in the family is how we determine our worth And if we are unable to do it, if we are bedridden, or our activities of daily living have come down because of that, we feel like we have lost position, and so that is then linked with feelings of self-worth. And then comes to the spiritual aspect. And by spiritual, I mean that even people who are non-religious can feel this aspect of pain. So has any patient ever come to you and said, why me? Why did God do this to me? Or why am I going through this? I have never wanted harm for anyone or done harm to anyone. Why am I going through it? This is a spiritual aspect of disease. And is this because of my past sins? And is this because of something I have done in my previous birth? Or is somebody else actually trying to do something to me? And so this is the spiritual aspect. So there you have the 4 aspects of total pain. And know that if you are going to address only the physical aspect as you go ahead and treat patients, then it's not going to be completely gone. And there are many patients in whom the psychological aspect also plays into the physical aspect and will continue to feel the pain even if the physical aspect is gone, but the psychological aspect is remaining. So this concept of total pain that we just spoke about, let's have a bit of interaction. Let's have a bit of everybody sort of chipping in and telling me what they feel also, because pain is going to be a long subject, and I would like some of us to keep interacting with each other and talking with each other. So you can see this gentleman. He has a sorrowful expression on his face. He's got cancer of the buccal mucosa. He has persistent, unremitting pain over the jaw that hasn't gone down for 2 years. He has a foul-smelling wound. He's socially isolated. He is insomniac. He is anxious and depressed because of the disease. He was a carpenter, but he's now unable to work, and he says, "Why me, God?" So I've given you a lot of clues here. Can you tell me which aspect of total pain are we talking about here?
Spiritual.
Okay,
And social.
which one is the spiritual?
The last one, why me, God?
That's true. That's true.
And social, he shuns company because of the foul-smelling wound, socially isolated. And psychological, depression.
Depression, anxious.
And we had a physical pain where there is a persistent and remitting pain over
the actual physical pain. Exactly. So this is how it's happening for him. There is the physical aspect, the social aspect, the psychological aspect, and the spiritual aspect. So in a short case summary, you now know that there is so many aspects of pain involved, and so much of it that we at least have to address, even if we are not able to completely make all these problems go away. But we have to make sure that we address them, we understand them, and then maybe we try. So this was the introduction to pain that we spoke about. And now we go on to the pathophysiology of pain and its classification. So pain is primarily of 2 different types. There is nociceptive and there is neuropathic. Nociceptive is pain that arises from actual or threatened tissue damage because of non-neural tissues. And this is tissue damage to non-neural tissues. And this is because of activation of nociceptors. Whereas neuropathic pain is caused by a disease or a lesion in the nervous system. So that could be the nerve, the spinal cord, or the brain. Any part of the central nervous system can be involved in neuropathic. So nociceptive is actually further divided into the somatic or and the visceral aspect. This is also known as the mechanistic classification of pain. So the somatic aspect will be your peripheries, your musculoskeletal system. So myofascial pain, tension, headache, cramps, and visceral is going to be organs, hollow or solid. So it could be an intestinal colic, it could be a liver capsular stretch due to a tube. It's important to know this because pain medication or targeted therapy will be, or targeted pain relief will be different for different regions. And then, of course, you have neuropathic, which can be because of a spinal cord compression, a nerve compression. It could be brain damage, any of them. So some more characteristics of nociceptive and neuropathic pain. Now, nociceptive, as we know, is stimulation of the nociceptors. There are nociceptors in the soma as well as in the viscera. It can be localized or diffused. Usually somatic is more localized because the pain sensation is felt in a much more localized area. That's how the nociceptors are present in the skin. Whereas visceral pain is less, its characteristic is such that it is diffuse because the perception is such in the brain. You can have, if you ask patient for descriptors of pain, how is the pain like? It could be throbbing, it could be aching, it could be gnawing. But there are no other abnormal sensations. And we'll come to abnormal sensations when we talk about neuropathic pain. So neuropathic pain is because of abnormal impulse generation. And that could be in the peripheral nervous system. It could be in the central nervous system, spinal cord or brain. You may see patients describing neuropathic pain in a dermatomal or a neurodermatomal distribution. So distribution of either a particular nerve, a particular nerve root, a particular plexus. It could be any of these. And then if you ask patients to describe what kind of pain it is, there could be burning pain, there could be shooting pain, there could be lancinating pain, there could be pricking or pins and needles kind of sensation. There could be associations with hot and cold, say water or perception of hot and cold temperature. And then there are abnormal sensations which are also seen, which is allodynia or hyperalgesia. So hyperalgesia is that a less painful stimulus is considered very painful, and allodynia is that a non-painful stimulus is considered painful. So these are the abnormal sensations that happen with neuropathy, which don't often happen with nociceptive pain. So this is just a diagram to explain all that I just said about neuropathic and nociceptive pain. If you see here in the skin of the soma or the periphery of or your musculoskeletal system, that is where your somatic nociceptive receptors are. In the viscera are where the visceral nociceptive receptors are, and they will both then travel through the peripheral neuropathic system into the central neuropathic system. And so this is about your nociceptive pain, whether it is somatic, whether it is visceral. And then you come to the neuropathic pain. Now the neuropathic pain is that there can be injury or an abnormal stimulus anywhere along this path. And so that is anywhere in the peripheral nervous system or in the spinal cord or all the way into your spinal cord tracts and into the brain. Okay, now we come to the various. Okay, somebody has a question. Does anybody have a question? Would you like to?
Yeah, can I ask a question?
Yes,
I'm one Premnath Kotur.
Go ahead.
Can there be a pain without nociception?
What do you mean by that, sir?
Without a tissue injury, can there be a pain?
Yes, that is why even sometimes non-perceived stimulus, there can be pain. So is there a particular kind of case you're thinking about, or a particular kind of something that you've read about you're thinking about?
Yeah, many a times we encounter patients who do not obviously have any kind of a tissue damage, either a somatic or a visceral, but still the patient says it hurts, patient says it pains. I want to emphasize on that.
Okay. So I think that here what you are talking about is maybe the entire aspect of total pain, where there may be a lot of other psychosocial phenomenon which may be affecting it, and some small problem in the body in which the physical stimulus that causes the pain is actually minimal, but the social and the psychological aspects of it are so high that the perception of pain is a lot. There is a lot about pain actually, which is subjective. The way I feel pain will not be the way somebody else feels pain. And if you feel pain, the way one person feels pain when they are feeling sad, and the way one person feels pain when they are not feeling sad can also be different. So if you think about the way an individual perceives pain, and if we go into that discussion, it's going to be quite a long one.
Anyway, thank you very much.
Just sorry to interrupt, Dr. Khanna. Even the diabetic neuropathy is a very good example of what he asked. So what you have been explaining is exactly the same. No? So they need not be a physical damage, but they could have all neuropathic pain could be as what you have been explaining, and that is one of the thing I think the Dr. Premnath is also trying to ask. Is that, am I making things connecting to each other?
Yes.
So all types of peripheral neuropathy, those type of things, no, alcoholic neuropathy, all those things. But neuropathy as such can be due to disease, trauma, that can have a very big list of causes. So as Dr. Smriti Khanna mentioned, pain as such itself is a very big entity. Each one you can expand and see. Based on this, as we will be seeing more sessions, and more reading material also will give you insight on all this.
Yeah,
I just thought
have
to
one
add
remark?
on. That's all.
Can I say
carry on.
one remark?
Yes,
See,
please.
many a times when the patients with pain approach us, we say that nothing is wrong, everything is fine. Your pain is in your head. Your pain is in your brain. This is what we say.
No. So for that, I think let Dr. Khanna carry on, and we will. At the end of it, we will explain a little bit more.
Okay, thank you.
Carry on, Dr. Khanna. Just to add on only is what I thought of explaining.
Correct. Thanks a lot. So we were talking about the physiology of the central and the peripheral nervous system and the nociceptors that leads to pain perception. And now let's talk about a few aspects of the pathophysiology of pain, in which what happens when tissue damage happens or when something goes wrong, and that then leads to pain or painful responses. So one thing that can happen with tissue damage is increased excitability of nociceptors. And then also the threshold for activation of these nociceptors reduces. And this will then lead to what we call as peripheral sensitization and hyperalgesia. So if you see here, more and more amounts of if you see here, more and more excitability of nociceptors happen. The threshold at which they will start firing and then go all the way across the peripheral nerve is lower, and then this leads to hyperalgesia. So this leads to peripheral sensitization. So this is one term that is used in the pathophysiology of pain. The other one is that there can be continuous release of inflammatory mediators. This will then activate dominant receptors. There will be more receptors at the site of the tissue damage, and this is known as peripheral recruitment of receptors. So, and once there are more receptors involved, increasing amounts of stimuli will then go up the spinal cord and then cause more perception of pain. These are actually terms which are quite important in chronic pain, when even after the stimulus is gone, if you have increased peripheral recruitment, or if you have increased excitability that goes on for a long period of time, this is how the cycle of chronic pain perpetuates. And then we have what happens centrally, and this happens a lot in children and adults with severe neurological impairment. So there may be a noxious input at some point of time, and that will increase the excitability of the dorsal horn neurons and reduces the threshold for activation. This then causes central sensitization and secondary hyperalgesia. This can happen in central as well as autonomic nervous systems. And that is why there can be a lot of GI issues that may be there even in the absence of a stimulus. A lot of other autonomic symptoms like you get in central regional in CRPS 1 and 2. And this there is a lot of these things going on in chronic pain. So which is why in chronic pain, even in absence of stimulus, you can have continuing pain, continuing associated symptoms with pain like autonomic symptoms. And those can go on for a long time and can be difficult to treat. Yeah, so this was the central sensitization that I spoke about. Now, along with this, there are other somatic effects that happen. As a result of pain, there will be vasoconstriction to that area, and there will also be skeletal muscle spasm. So this in itself can also contribute to the pain and contribute to the immobility as a result of the pain. So this, in short, was the pathophysiology and the different aspects that are involved in pain perception. So I was just talking about chronic pain, and let's just have a short discussion about acute versus chronic. Acute pain is transient. It has a positive meaning in the sense that there is protection from injury. So the very reason why we do feel pain, why we do perceive pain, is to prevent further injury and to protect us from more injury. And that is what we mean when we say that it has a positive meaning. It can have more autonomic responses because that's when a lot of other hormones are also released. And then the intensity will reduce as healing progresses. So this is about acute pain. When it comes to chronic, chronic is usually, pain is usually labeled chronic pain once it is for more than 3 months. It's going to be persistent, it's going to be progressive. Like I said, it can persist even when the stimulus has gone. So there is no injury that actually the body needs protection from. There is no problem that is currently going on. A lot of neuropathies actually are like this. And so it's a kind of a negative meaning. It serves no useful purpose because there is nothing to save the body from. Here, the autonomic responses can then settle and other responses can become more dominant. So this can then actually cause more psychological responses such as lethargy, a lack of pleasure in life, and personality changes. So this is what you've seen in the case that we have discussed, that because he's had pain for 2 years, he is now having, he's depressed, he's anxious, he's not able to sleep, he's socially isolated, he doesn't go out. Then there are some other aspects of pain, and this is especially important in cancer pain. We have breakthrough and we have incidental pain. So, and both of these can happen in cancer pain. Incidental pain is pain that is associated with any particular movement or any particular activity. So, for example, a patient with a neuropathic pain involving the jaw may have an increased pain when there is a gust of cold air, or if he tries to brush his teeth. And so that is incidental pain. And then breakthrough pain is, if you see here, you will have a standard baseline pain. Sometimes it might be something that has been controlled by medications. And then you will have a pain spike, which is known as breakthrough pain. So if this line is the kind of the threshold at which the medication is acting, that is, if pain is lower than this line, that means that, or the stimuli are lower than this line, then that means that the patient will not feel pain. Any stimulus that goes above this can cause breakthrough pain. And this is a phenomenon that we see in cancer patients even when they are on treatment. And this is the rationale behind what you will read later on, or what you will study later on when we discuss opioids, about giving breakthrough doses or SOS doses of opioids or other medications. And then one more important thing to know is that many pain conditions are mixed presentation. You can have nociceptive, you can have somatic nociceptive and visceral nociceptive. You can have somatic nociceptive along with neuropathic. You can have pain that is because of two different organ systems or two different diagnoses. So you can have a patient with diabetic neuropathy who also has cancer. And it's important to know that because we will have to then treat accordingly. So we have now covered pain introduction and we have covered pain classification and pathophysiology. We are going on to the assessment part. But before that, I'd just like to pause and ask if anybody has any questions. I'm just going to stop sharing for a minute. So Shri Sudha madam has spoken about migraine. I think we were talking probably about this when we were talking about the pain without any obvious stimulus. But in migraine also, there are neural pathways that are affected. I'm not going too much into detail, and probably I'm not the right person also for it. But anyway, any other questions that anybody else has? How do you differentiate clinically between incidental and breakthrough pain? That's a very good question. Incidental pain usually occurs after performing a particular activity or some particular phenomenon. And so you will see that it is associated with that. So you will ask the patient again and again, and they will tell you that I did this and hence, and that is when the pain came. So the patient also will be able to tell you. Breakthrough pain is a pain that is not associated with any particular movement or any particular activity or phenomenon. It's a pain that can arise even when the patient is lying down, doing nothing. And this is a common feature of cancer pain. The pain fluctuates. It does not always stay at a stable level. That is in itself a feature. Pain assessment, we are going to come to end of dose pain and BTP difference, please. So end of dose pain will also be quite regular in the sense that the patient will tell you that morphine effect has lasted for only 3 hours for me. And then in the last 1 hour, I'm quite in pain. Breakthrough pain is erratic. It doesn't have to occur every day. It can occur once in 5 days, once in 2 days. It will not occur at the same time every day. So that's how you will differentiate. Okay, shall we move on? All right, everybody can see?
Yes.
Okay, so now we have pain assessment, and I'm going to touch upon a lot of the assessment and just a little bit about some of the drugs after this. So some basic tenets that you have to keep in mind when you are assessing somebody's pain. First is, like I said to you in my second slide, you have to believe the patient regarding their pain. And so you have to accept the patient's description. This is sometimes a barrier that is there in our minds, and we only cannot get over it. Because many a times we have seen in our medical education or practice a lot of doctors, of relatives just dismissing pain. And so that is the first barrier that we have to overcome when we are practicing as palliative care physicians. Accept the patient's description. And then it is about taking a thorough pain history. So that will include, we're going to talk about it in the slides to come, but that will include severity of pain. There are some mnemonics that you can use for pain. There can be, you have to ask about how the pain is interfering with daily activities. How is it impacting their psychological state? and what have they, a good drug history. So what have they taken before for it, and what was their response to it. To also ask for a past history of drug and alcohol dependence, because obviously you want to make sure that you want to know that this patient is at risk for dependence or addiction in the future. And then you have to look at comorbidities, dementia, or mental illness. Basically, along with pain, you will also be taking a normal regular history, a past history of the patient and all the conditions that they have gone through. And it's also important to learn to ask about bowel, bladder, sleep, and appetite, know how the pain is impairing each of them. One very good clue for severe pain is that if a patient has pain that is keeping him up at night, then that is then I would count that as severe pain, and keep that in mind when I continue my assessment and my management. So these are some other points. Okay, now I'm just because I'm talking about taking a pain history, I'm also going to be talking about the setting when you are going to do it and how you are going to have a history taking session with the patient. A lot of this is about communication, and you will be having a separate class on communication. So this is just an introduction, just a prep for what's to come. So once you know that you have to go to see a patient to assess their pain, you will first prepare for the interview, confirm the medical facts. So nowadays, most of the times we usually have diagnosis at hand before we see the patient, because they would have gone to multiple specialists before they would have come to you. So do your homework about what they have, how it can cause their pain. Read about the prognosis of the disease and treatment that has occurred, and talk to the other specialists involved or the referring physician involved. Create a conducive environment, allow privacy. It may not be a closed room, but just something which is a little secluded is also fine. If you are able to sit at eye to eye level, that makes the patient more comfortable. They will be more forthcoming with their questions and their thoughts. So taking a pain history at the bedside when you are standing and the patient is lying down is not necessarily as good as either sitting with them or being at their same level. Allot adequate time for it. So try and prevent interruptions, try and not take phone calls or have other people barging into your clinic at the time. And determine who else the patient would like to be present and who can actually add to their history. So the closest caregiver or the people living with them. I'm seeing a few questions. I'm just going to finish the assessment bit, the PQRST bit, and then get back to them. So yeah, so I think we finished with the setting in which we have to take a pain history, and now we come to pain assessment. So there are a few mnemonics involved. You are welcome to take whichever is comfortable for you, as long as you are just able to ask all the questions that are part of it. So PQRST is a quick mnemonic to ask about the various aspects of pain. P means provocative or palliative features. So what aggravates it, what improves it, what suppresses it, the pain. Q is the quality of pain. We discussed this when we did nociceptive and neuropathic pain, right? Yeah. So is it burning? Is it lancinating? Is it throbbing? Is it dull aching? Is it pricking? Are there abnormal pain sensations involved? All these things. R is for radiation of the pain. So where does the pain radiate? If it's neuropathic, it can radiate from back to one limb. If it's pain which could be visceral, it could radiate. For example, gallbladder pain can then radiate to the shoulder. So ask about radiation. Then 4 is the severity and site of the pain. So how severe is the pain? Where is the site of the pain? Are there multiple sites? And then T is the temporal pattern. So how long does the pain last? Or what is the diurnal variation like throughout the day? Is it continuous? Is it intermittent? So that is that. So P for provocative or palliative features, Q for quality, R for radiation, S for severity and site, and T for temporality. Okay, so now let's see how much of this you remember. This is the case. A 50-year-old man, a 50-year-old man with newly diagnosed metastatic prostate cancer with mets to the bone, comes with moderate pain in his hips, chest wall, hips, and shoulders. What questions are you going to ask to assess his pain? Severity, radiating or not, okay. Diurnal variation, that's correct. Is it interfering with sleep? Excellent. What aggravating factors are there? What relieving factors are there? What is the quality? Is there pain on activities like walking? Excellent. A lot of excellent points. When was the onset of the pain? Are there any neurological features along with it? Provocations with movement? Is it aching, gnawing, continuous, intermittent, long? Is there a breakthrough pain? Excellent. Is it progressive? Does it interfere with walking? Excellent. Whole lot of good answers. So let me just go back. Are you changing your daily activity with relation to the pain? That's a very interesting question to ask. That are you doing something? Are you not doing something now which you were doing earlier? So sometimes a patient will not be able to tell you how bad the pain is until you ask questions like that. And so he's realizing that he has either reduced his movement, he stopped going down for a walk, things like that is then hampering his pain. Okay. So, like I said, there are a couple of mnemonics that you can use. If you are not going to get too confused, then I'm going to show you another mnemonic that we can use to ask questions about pain. So this is called as Socrates. Socrates. So it's going to be similar to what we have already discussed, but we start with site. So where is the pain? Is it in more than one area? Then we go on to onset. When did the pain start? Sudden, gradual. Then we go on to character. So what's the pain like? Describe the pain. What's the quality of the pain? Then we go on to radiation. We've already discussed that. Then we go on to associating aspects. So any other signs or symptoms along with the pain. If there is pain in the abdomen, is there vomiting also? Is there jaundice also? If there is a limb pain, is there power loss or sensory disturbance also? And then we come to time. So how long does the pain last? And all the questions about temporality, which we had come to. Then we come to exacerbating relieving factors. You know what those are. And then we come to severity. So how bad is the pain? Does the pain interfere with daily activities? And in severity is where we will use some pain scales, which I'm going to come to later. So you can use a form of analog scale, which will help quantify the amount of pain. And then the other thing that begins with S is significance. So this is a very interesting question to ask, because it is going to lead you to your total pain questions, to your total pain aspect, to the biological model. So how much does this pain trouble you? What things does it stop you from doing? What do you think it means? Thinking about the psychosocial and the spiritual aspect. Does it make you worried or anxious? Psychological aspect. And a lot of their fears can then come out. So whereas all the others are pretty much similar to what we had discussed with PQRST, this significance questions are quite important, because it means that you can now go one step further, where you will treat the physical pain also, but you'll have a better understanding of your patient, of what is troubling you, and that is going to help you a lot in the long run. Okay, so now I've basically what we have covered up till now was history in the history part of the assessment, and now I'm coming to the physical examination. So the general state of the patient, is there any organomegaly? Is there any area of tenderness? Is there any musculoskeletal aspect? Or rather, have you done a musculoskeletal examination, a neurological examination? It's going to be a focused physical examination mostly in our OPDs and in our wards. So, and then this is one other important thing, that if a patient comes to you with pain in one particular area, you may sometimes have to just treat the pain and then facilitate a workup. So you have done a basic workup, but you want to go for an ultrasound and he's not going to be able to allow you to put the probe on the stomach. So you may just have to give him a paracetamol and then go ahead and facilitate a workup for the pain. And then review and assess response to treatment. So one important aspect for us when it comes to pain management is review, because usually when we start strong opioids, especially, we ask for patients to review with us in 24 hours. It could be over the phone, it could be in person. And sometimes you may have to change opioid doses within the day if it's severe pain. So reviewing and assessing response is a very important aspect for us when it comes to pain treatment. And this is also where our pain scales will come into importance, will come into significance. Okay, then we get to the appropriate investigations, your blood tests, X-ray, CT, MRI. Know that it can be a complication of some of the illnesses that they have. He could have multiple myeloma and come with hypercalcemia, and that in itself could contribute to the pain, things like that. Then you evaluate the extent of the disease and consider treatment, assess the other factors influencing the pain, and then review again. Cancer is progressive, other diseases also, but especially cancer, things change very quickly, side effects develop, and that's the reason to review. And also remember, if you are treating pain related to cancer, or if you are treating pain in a cancer patient, it's not always to be attributed to the cancer only, because it could be completely unrelated to the cancer. He could have a head and neck cancer and just come with cholelithiasis or cholecystitis. So now we come to the tools. Most of the pain scales or the pain tools that we use, especially in adults, we try to do it. We try to use quantitative tools. We try to use analog scales. So one very commonly used scale is the numerical rating scale, where we ask patients, we show them this scale, or you can just quickly draw this scale of 0 to 10 on a piece of paper and show it to them and say that from a scale of 0 to 10, 0 being the least and 10 being the most, how much pain do you feel? Most patients are able to answer this. It does not, their level of literacy does not matter, their socioeconomic status does not matter, where they are coming from does not matter, whether they're male or female does not matter. I would say about 80 to 90% of my patients are able to answer this. Hello. And then you have the visual analog scale, where you can use visual cues like that to suggest no pain or worse pain ever. You also have body diagrams that you can use for pain assessments. Many palliative care centers actually have these body diagrams in their assessment sheets only. And so you can use this in many ways. You can ask the patient to shade in the area where there is a pain. You can use different colors for different severities of pain. So he may be using red to paint this aspect. And so that means that there's a lot of pain in this area, and there could be some mild pain in this area. So he may be shading it yellow. Or you just ask the patient to point on the diagram where they are feeling the pain. And this is a very quick, like a ready reckoner. Whenever you are seeing or somebody else is seeing the patient, and they just look at the diagram and they know where the pain is. Then you also have pain scales for those patients who are unable to vocalize, unable to describe the kind of pain that they are feeling. So patients with dementia, patients who cannot verbalize, you have something called as the ABBY pain scale. There is also the PAINAD, PAINAD pain scale for patients with dementia. So using all these questions and then recording based on this. So here the total pain score and the correlation with severity is a little different than this numerical rating scale correlation of severity. So here in our numerical rating scale, the severity is 1 to 3 is mild, 4 to 6 is moderate, and 7 to 10 is severe. Whereas here it's a little different. So this is just to keep in mind, because most of the times the pain scale that we will be using will be the numerical rating scale. Now there are, yes, you're right, there are some patients who may not be able to answer these things. Some patients who may seem confused when you ask them about pain severity. What can you do to be able to establish pain severity? One trick that I use sometimes is asking for pain percentages. So out of 100%, how much pain are they feeling? Is it 25? Is it 50? Is it 75? Many times, even when they are not able to answer the 0 to 10 scale, they are able to answer the percentage scale. For some older patients, we still use the 1 rupee pain scale. So we ask if the pain is 4 annas, 8 annas, 12 annas, or 1 full rupee, and then we correlate to the pain severity. And sometimes all I do is I ask, is it little or is it a lot? Sometimes all you need to know is it mild or is it severe? If nothing else is working, then that's the best. Then that's what you can ask. This is not a way in which you will be then able to assess the reduction in pain over time. It's a cruder assessment, but you're still able to at least understand what sort of medication you want to start him on. And then it can also help you in tapering going forward. So these are some of the various tools that we use when it comes to pain scales. Now, I think we will, before we come on to the case, I'm going to again stop and ask if there are any questions about pain scale. Okay, no questions, then we can go to the case again, and I can ask you some questions from that case itself. Dr. Sujata, I haven't understood what you're trying to ask. Any pain scale for blind persons, you can just ask if it is a little or a lot. And you can ask Anas. You don't have to actually show him the visual analog scale. They will be able to understand even without this. So many times during rounds, I am only directly asking patients that, and it's a 1-sentence question, that if you were to rate your pain from 0 to 10, 0 is the least and 10 is the most, how much would it be? So many times I don't have the pain scale in my hand and I just ask them. Little more elaboration on the Abbey scale. So basically, if there is a patient with dementia who is not able to verbalize, or you are not able to understand what he or she is trying to say, this is going to be an observational scale. So this will be sort of like an objective scale, whereas the scales which you are asking patients directly is a subjective scale. So that is one more difference also. Now, I can just quickly go through the points. These are what we sometimes call as pain behaviors, or cues that can explain or that can give us a hint that the patient is in pain. So one is that the vocalization that they are doing, whether they're whimpering, groaning, or crying, their facial expression, frowning, grimacing, tense, frightened, the change in body language, so guarding any part of the body, fidgeting, withdrawn, any of these things. behavioral changes. So increase in the amount of confusion can also be a hidden this thing of pain. So that's also important to know. So refusing to eat or alteration in their usual pattern or their usual schedule. And then you can have physiologic changes, which is what sometimes we see in ICU patients, right? Changes in pulse, blood pressure, flushing, pallor, changes in temperature. And then actual visual evidence of the possibility of pain. So skin tears, pressure areas, contractures, injuries can be noticed. Pediatric pain scales and pain assessment in children. So pain assessment in children above the age of 8 years is the regular numerical assessment scale, which will be this one. This regular numerical rating scale is what you will use for children above 8 years, because 8 years is when they attain numeracy, and so they can tell you, they can deal in numbers and tell you how much they're feeling. So again, for children, subjective pain scales will be above the age of 8. Lesser than the age of 8 are going to be objective or observational pain scales. Like you have ABBY. ABBY cannot be used in pain assessment in children. It's not validated for use. But the pain assessment that we frequently use for children is one which is called FLAC. I actually don't have a picture of it right now, but I think at the end of the session I can show you the scale. So FLAC is FLACC. It stands for face, legs, activity, cry, and consolability. And this is also an observational scale. It's actually a lot of them are similar to what you are using in the ABBY pain scale, but we use that because that is validated in children. So face will be the facial expression, legs will be if they're holding their legs up or kicking their legs, activity will be if they are withdrawn or they are hyperactive. Cry is going to be if they are excessively crying or whimpering or moving, and consolability is what level they will be consolable. So this is used in patients, say like 2 to 5 years or so, 2 to 6 years or so. And then in smaller scales, in smaller patients, you have the NIPS, or the neonatal infant pain scale. So that is also similar to the FLAC, but there will be some changes here and there in that. Okay. All right, so we are going back to the same case that we started with. So this, just in case you have forgotten, it's the 40-year-old man. He's got cancer of buccal mucosa and he has persistent unremitting pain on the jaw since 2 years. He has social isolation, he is depressed, he's anxious, he's insomniac, and he has a lot of spiritual distress. So we are now going to make a pain diagnosis for this patient. So when you ask him further about his pain, he says that he has a continuous pain over the jaw, which is 6/10. And the quality is that somebody has held it tightly. Then he also has a shooting kind of pain, which radiates from the jaw to the ear, which is intermittent. And then he has pain on chewing and on swallowing. And then he has pain when the dose effect wears off. So can you now tell me which of these is what? So the first one, continuous pain over the jaw as if someone has held it tightly. What type of pain would you label this?
Type of is moderate. Are you asking about the scale?
Actually, that too, the severity it's moderate.
Moderate.
When we go to the classification of pain, then what would you call it? This is somatic, right? So this is
somatic.
This is somatic.
Continuous, persistent.
This is continuous, persistent. It's in the area of the wound, and so this is somatic nociceptive pain. It's right in the area of the cancer. Then he has the shooting kind of pain, so which is radiating from the jaw to the ear. What type of pain is this likely to be? This is severe, which is correct. But
Neuropathic?
neuropathic. This is likely to be neuropathic because there will be nerve infiltration from the tumor. And then he has pain on chewing or swallowing. So what type of pain what would you call that?
Visceral?
No, this would be pain in that same area while chewing or swallowing. Not allodynia.
Incidental pain.
Exactly, incidental. And then pain when the dose effect wears off.
End of dose pain.
Correct, end of dose pain. So that's absolutely correct. So this is what this one is end of dose, not breakthrough. Otherwise, everything else we have got. Okay, so his pain diagnosis is that the site of the pain is the jaw. The severity of the pain is 6 on 10 and 8 on 10. So he has moderate to severe pain. The type of the pain that it's mixed. So he has nociceptive as well as neuropathic. And there is radiation to the ear. The aggravating factors are movement of the jaw, chewing and swallowing. The relieving factors are medication. And it's affecting the daily activities, his sleep, his appetite, his interpersonal relationship, his family relationships. So if you see here, when we looked at PQRST, we have added all of that here. So we have added palliating and improving factors. Then Q was for quality of pain. So we have looked at that also. Then R was for whether it is radiating. S is the site and the severity, and T is the temporality. Temporality I haven't added in here, but we know that it is there for 2 years. One other thing that we could ask for temporality is that with medication, how many hours does it get alleviated? And you have also gone and asked the significance aspect of the Socrates mnemonic, which says that how significant it is. Is it, what activities is it affecting? What does he feel about it? And how is that making him change his daily routine and his life? So this, in effect, is a pain diagnosis. This is one of the most important sort of aspects of a good assessment in palliative care. Okay, now I'm coming to a little bit about pain management, wherein I'm just going to talk to you about some of the drugs that are used. So before that, we go to the principles of pain management. You need to do a thorough assessment. There has to be good communication when you find out about the patient. Reassure the patient that we will be able to take care of his pain. We may not be able to reassure him that we will be able to 100% improve his pain, but also we will definitely be able to reduce it. Discouraging the acceptance of pain. Now, this is something that happens where, especially in patients with cancer or with families that are quite fatalistic, they will say that, you have to just accept pain or you have to bear pain. I mean, it's okay to bear the pain of a toothache, which goes away in half an hour or 1 hour or after after a bout of antibiotics. But for a patient who has cancer, who's going to have continuous pain, where sometimes even the treatment of the cancer is not going to help his pain, or a patient with diabetic neuropathy, why must they continue to live in pain for the rest of their life? Especially if you think back to that aspect which I told you about chronic pain, and how chronic pain can actually cause vegetative responses, so that they will become withdrawn, they will become psychologically down. It can actually cause depression. They may feel socially isolated. They may not feel like they could go out and do their daily activities or socially mingle. So that's one of the principles of pain management. And then patient participation. So asking the patient and not the caregiver. If the patient is able to speak, asking them how they are feeling. Many a times what the caregiver tells you and what the patient tells you will be quite different. And then review and then check the adherence to the plan. So this is the principles of pain management. Now we come to some barriers. So, and these can be patient barriers or clinician barriers. So what barriers do you face as? What barriers can doctors have when they're trying to treat the pain? One is that they may not be able to assess the pain properly. The second is that they may not be able to treat the pain properly. They may not feel that the kind of pain that the patient is feeling warrants treatment. There can be a lack of knowledge regarding options. There could be a fear of addiction or tolerance. And there could be our own beliefs. Like we could also feel that it's okay to tolerate pain. And a lot of these can be barriers to pain management. And then what are the barriers to pain management for the patient themselves? So they could also have fear of addiction. They could have a concern about tolerance. They could have a fatalistic attitude that if you have cancer or if you have such and such disease, you will be in pain. They could have this misconception that good patients don't complain, or a good person does not complain about what they're feeling, and then pain is something to be borne. Some patients can have fear of injections. This is especially important in children. And then you can have underreporting because of fear of disease progression, which is a real thing, that a symptom that has gone has actually now come back. And so they are very worried that it can have caused disease progression. You could have concern about the side effects and worry that if you talk to your doctor about pain relief, then that might distract them from the cure or the treatment. So that was some of the barriers. And now I come to the WHO pain ladder. So like I said that the scales are the most important part of pain assessment. This WHO pain ladder is actually the most important part of pain management. So the ladder is step 1, step 2, step 3 for mild, moderate, and severe pain. So step 1 is non-opioid pain medications, which is paracetamol. It can be NSAIDs with or without adjuvants. And I'll come to what adjuvants are. And then step 2 can be mild opioids, or opioids which are used for mild to moderate pain. And then step 3 can be opioids for moderate to severe pain, or severe opioids. Step 2 will be weak opioids, and step 3 will be strong opioids. So mild pain, moderate pain, and severe pain. So this is the pain ladder per se. There are other principles of the WHO pain ladder, which I'm now coming to. So bear in mind that this WHO pain ladder was first, because a lot of palliative care and pain management was first directed towards cancer. So a lot of this is also directed towards cancer. So the pain ladder says that management should be by the clock. So continuous pain means continuous relief. If there is a patient who is actually having intermittent pain, then you can give intermittent pain medications, but continuous pain will be continuous relief. So prescribe drugs that are round the clock, or which will give a pain threshold will be reduced, the pain level will be reduced throughout the day. So prescribed drugs according to their duration of action. So 8th hourly, 4th hourly, 6th hourly, whatever is needed, not arbitrarily or on a as needed basis. Then you come to by the mouth, because oral medications are the most easiest to give. You have to give medicines orally as much as possible. This is the simplest route. The patient can take it by himself, does not need to be dependent on anybody. And obviously injections are also a source of pain. And then you come to by the ladder. So choose medications according to severity of pain. Mild pain, usually opioids are not used. Moderate pain, weak opioids. And severe pain, strong opioids. And severe pain, and also another important thing is if you encounter a patient who has severe pain, like for example, Prakash probably has severe pain, you start with level 3 medications directly. You do not have to go through the steps and then reach level 3. And then you have the individualized approach, wherein the prescription should mention the dose for breakthrough pain. You have to choose the right drug, the right route, and the dosage based on the comorbidities, the drug interactions, and the side effect profile. If you want to prescribe a patient strong opioids and the patient has renal failure, morphine is not the first choice. Although morphine is in general the first choice, but not the first choice for renal failure. So you may have to prescribe him fentanyl. So drug interactions and side effect profile. In short, each person has to be managed holistically. So by the clock, by the mouth, by the ladder, and individualized approach. And the 3-step ladder, WHO pain ladder. This is the most important takeaway from the management aspect. Now we come to drugs for pain management. I'm only touching upon these. They're going to be discussed in detail in the next 2 or 3 sessions. Non-opioids is paracetamol and NSAIDs. Bear in mind that while step 1 includes only these and adjuvants, you can continue to use this in step 2 and step 3. So when you are giving a patient weak opioids or strong opioids, you may still continue to keep them on NSAIDs, on adjuvants, on paracetamol. So that's why it says plus step 1, plus step 1. So that's your non-opioids. Your mild to moderate opioids are codeine, tramadol, and tapentadol. The severe or the strong opioids and opioids for severe pain is morphine, fentanyl, and methadone. And then you have adjuvant analgesics. Adjuvant analgesics are pain medications, are medications that are not traditionally classified as pain medications, but can help in reducing pain. So when it comes to neuropathic pain, you have tricyclic antidepressants, anticonvulsants. All these can relieve neuropathic pain. Pain because of spasms, especially visceral spasm, can be relieved by anticholinergics. Muscle spasms, muscle relaxants can also help. Neuropathic pain and MDA receptor blockers like ketamine can help. And then you have bisphosphonates, which are used for pain management in cancer patients with bone meds. You have local anesthetics. You get local anesthetic patches also for localized pain. And steroids can also help in some kind of pain because they reduce a lot of inflammation around the tumor, and that itself can help alleviate pain. So this is a short introduction to the drugs that are used in pain management. These are some of our common NSAIDs used. I don't think I need to explain any of this. I'm sure all of you know about it. Weak opioids, codeine, tramadol, and tapentadol. Codeine is not really used that often because there is a lot of pharmacokinetic variability involved. That you will have ultra-fast mobilizers, slow, ultra-fast metabolizers, fast metabolizers, slow metabolizers. And so it's difficult to give codeine because the drug concentration can be very, very less or very large inside the bloodstream. Now, tramadol and tapentadol are our most commonly used weak opioids. And tramadol has been there for ages. Tapentadol is a newer one. Both also have some neuropathic effects, so that also helps. And then we come to our strong opioids. So oral morphine is the gold standard of treatment for cancer pain because it's cheap. Its method of administration is orally. Out of most of the strong opioids, it's the one which is the most easiest available. It has 2 major metabolites, morphine 3-glucuronide and morphine 6-glucuronide, and M6G is the active component. It has to be administered with caution in patients with renal and liver function impairment. There is no ceiling dose, and it should be titrated according to its pain. This will be dealt with in detail, so this is just an introduction. Then we have fentanyl. Fentanyl is available as IV and patches. Most of the times we will be using in OPD practice, we will be using patches 12, 25, and 50. We use it when the patient has stable pain because if you are using a fentanyl patch, the duration of onset of action will be about 8 to 10 hours, 8 to 12 hours. And so it's not going to be easy to change the dosage based on the pain. So when a patient has acute unstable pain, you will start with morphine and then if needed, switch to fentanyl. And not to forget the non-pharmacological management of pain. This will also be covered later on because a lot of this is tips that your patients that you can give to your patients, and they will find it very helpful. Positioning and movement, especially in patients who are bedridden, who have bed sores, hot and cold packs, massage and touch, sleep, music therapy, relaxation techniques, meditative techniques, aromatherapy, diversional activities, and comfort, understanding, and time. Most important. So to summarize, pain is an important symptom. To be managed in palliative care, you have to have a good understanding of pathophysiology. You have to take a good history, a good assessment to be able to manage pain properly. There are many scales that are used for pain assessment, and we usually try and document it in our notes so that the next person seeing the patient knows what's happening. And pain management involves the use of opioid and non-opioid medication. Opioid medication is safe to use if adequately studied and if the patient is well followed up. Also, you have to believe the patient about their pain. A proper assessment will lead to a proper treatment. Review and reassess and remember the non-pharmacological measures, and know that any disease is the holistic component is always there, because if a patient feels something, the whole family experiences it. Thank you.
Patient has
Thank
severe
you very much.
constipation with morphine use.
So could you repeat, please?
Patient has severe constipation with morphine use.
Morphine always has to be given with anti-constipatory drugs, preferably not bulk laxatives, but drugs that will actually help move the GI system along. So this is something that we will also talk about when we do our opioids, our strong opioid stock. So many a times we will be asking you to write a prescription, and always the anti-constipation medicine has to accompany the morphine.
Okay, thanks.
Thank you very much, Dr. Smriti Khanna. You have done an elaborate explanation and detailed insight on the various aspects, what needs to be covered, especially like the pathophysiology. Those are the things. Today's topic was mainly on introduction to pain. As you mentioned many times, we have two more sessions or 3 sessions for pain itself, in which morphine, the queries what was asked now, will be dealt with in great detail. Even the WHO ladder, individual drugs in each ladder, adjuvants, everything. You will have 3 sessions on 3 more sessions on pain. So will be dealt with, everything will be dealt in more detail. She has given you an insight on everything already, what needs to be covered. So a big thank you for such an elaborate, and her expertise being in pediatric, she covered also what, like especially the pediatric pain thing, assessment and things will be the query which comes up many times. And that was a big asset for having her today, which she gave us so much on dealing with that also. And Dr. Aditi has got her hand raised. Do you want to ask anything specifically? If so, unmute and
ma'am.
ask, please.
Yes, ma'am. Actually, I am a practicing pain physician. One problem that I commonly encounter is, as soon as the neuropathic component of pain is explained, or chronic pain is explained, that how you are experiencing the pain, but there is nothing, no physical injury, but you are experiencing the pain since a long time, and that anxiety and these things play a role in this. As soon as the patient is explained, and as soon as a holistic things that I am or we are asking him to maybe consult a psychiatrist, or there is something wrong with the patient, and then they withdraw from the whole thing as a whole. I have experienced this twice or thrice. So is there a particular way whether we should be explaining the patient that this is happening to you, or just uh, just deal with the whole thing as if just prescribe and leave?
You are talking about chronic neuropathic pain, is it?
Yes, chronic pains, 2 years duration, 3 years duration, there
Correct.
is no physical
Yeah,
injury evident to the patient.
correct.
And
Chronic,
when you explain that, see, this was the problem and it has become this, and what you are experiencing is exaggerated by your anxiety and fear of disease, and that you have to relax a little bit, they immediately start thinking that.
I think her voice is breaking,
yeah,
maybe
but
due
I
to
understood.
internet issue. You
That's
could go
fine.
ahead,
I
and then
understood
if you
the
don't mind, I
question.
will add on later.
Yeah. Chronic pain is actually one of the most difficult types of pain to treat, and it often requires a multidisciplinary evaluation, multidisciplinary support. It will also require a long duration of treatment. Sometimes you will not be able to achieve 100% pain relief. And whilst it's difficult for patients to listen to all these things in one go, what we can focus on is that physical therapies and other therapies will help a lot. So there is a lot that the patient can do by themselves in their own house, which can help them. Also talk about what realistic expectations are you setting for pain relief. So sometimes even setting an expectation of, okay, let's try and reduce your pain to 30 to 40% of what it by 30 to 40% of what you have come with. So starting with setting those kind of expectations. So if you start with that, say that by the next time they come, you are not expecting the pain to be 100% better. I'm expecting it to be, say, 40% better. That may help in compliance. If you have a lot of if you have a lot of tools under one roof in one area, that may help in compliance. And I'm also waiting for Dr. Radha to maybe give some of her inputs.
See, thank you. As you're mentioning, I have been a pain physician for 12, 15 years now. So main things, I just wanted to add on couple more things. There is something called as neuroplasticity. What exactly that means is, like, the nervous system, the capacity of the neurons and neural networks in the brain to change their connections. See, many things were mentioned in today's session. See, more number of neurons can be there. And then that is what she mentioned, excessive amount of neuromédiators. So the threshold level can be changed. Like we all know ectopic in the heart, you can have ectopic sites. Then you can have new nerve, maybe, like, for example, to understand, I'm telling 50 stimulus means can become 100. Okay. And one more thing is said is, it's not a hardwired system. We show all this pathway. Okay. But it need not take the same route. Like we all know collateral. So many variations in the nervous system is possible. So that is one element. And second thing, there is something called as wind up. That is wind up is amplification. Simple. What is amplification? Is increasing. So a small thing can be made big, and that amplification can be short lasting, can be long lasting. It's called as wind up and central sensitization. These are all the technical terms used. So neuroplasticity is one of the reasons why, see, there were questions. For example, simple back pain you take. Injury happens once, many, many years ago, but that impact can last for many, many years. So these are all common examples. So these were the pathophysiology, physiology elements, what I wanted to add on. Then next is, in your questions, two important things. Does it affect sleep? Does it affect personal behavior? See, personal behavior, normally you can see and ask, they'll say, oh, he or she was not a person like that, was a very quiet person. Now he gets angry, or he snaps at people and things like that. Or someone who was very, very rough and outgoing can become totally introvert. So these are questions, if you ask, will either you ask or they may tell. So and so was not like this, now totally. So there are so many clues and cues which you can pick up. And last thing what I want to add on is, whenever you go like see patient and start giving treatment, first element is to explain all this to them. First tell them it is no, you're not mad or you're not. It is, this is what is happening. So whenever we do something called as a pain management program, first 1 or 2 sessions we will take to explain to the patient. Don't think or don't take someone is telling you all this. It's not. It is what is happening. So it has to be explained, and then tell them modes. And as Dr. Smriti Khanna mentioned, it's a very slow process, multi-speciality or multidisciplinary team assessment, multimodal management. So all these have to be taken. And in management also, there is something called a SMART goal management, which, see, again, this session is the first step. All these will be dealt in great detail in the next coming 2 to 3 sessions also. All the other modes of non-pharmacological management, everything will be covered. That's why multidisciplinary assessment, multimodal management, these two together will achieve. But again, sometimes above all this also, 100% may, well, at least some, they, when you have patients like that, 100% is not. They getting them to a stage where they can do their own activities and have so much relief in many symptoms does give relief and benefit. So these are the various things in various aspects to be taken on. And I think there were questions on interventional management, which also will be covered in one of these sessions.
Radha ma'am, Smriti ma'am,
Anything else?
thank you for the great
Dr.
talk.
Khanna, you want to add on? You can add on. And
No, ma'am. I think you covered it all.
so somebody else, I think, was trying to speak. Go ahead, please. If
Thank you, Radha ma'am and Smriti ma'am. I wanted to ask, what is the duration of your first interaction with the patient when he comes to you for pain clinic? So just as a practical point, not a commercial point, just as a practical point, how much time you give at first visit, second visit, and follow-up visits?
no,
Secondly,
go ahead.
one
Go
more
ahead.
question. If the pain is not reducing as per your estimates, do you get angry on yourself or do you feel helpless?
Dr. Smriti, go ahead first, then I will answer.
So if a patient is coming to me just for a pain consultation, it may not be a long one. It may be a short one. It could be a 10-15 minute consult. But if I am having a palliative care consultation wherein I am going to be discussing a lot about the disease and about symptoms to expect, if there are multiple symptoms that have to be taken care of, a lot of people need to I need to talk with, then it can go anywhere from 30 to 45 minutes. Follow-up sessions will be 10 minutes, 15 minutes, things like that. And obviously, if my diagnosis is not completely accurate, or if I'm not able to achieve the amount of pain relief, I will just try and make sure that I'm able to find out if there is another possibility, something else that is hampering or hindering. And Dr. Radha, what about you?
See, the time factor is very variable, okay, according to each one's availability of time, as Dr. Khanna mentioned. No? So it is variable. It could be a 15-20 minutes appointment, what you have. So, but at the same time, if you have, history thing, if you're running short of time, you can give some of these questionnaires to them to fill. Okay. So based on that, you go ahead. So that is one thing. And then the next consultation, see, in one consultation, you cannot or you will not be able to cover everything if you are going to be the only person doing everything. See, for example, in Pallium also we have a questionnaire in which we have the physical, psychosocial, all elements. It's a 2 to 4 page one, but varies. If I have another person with me, they will also do their part and I will do my part. So that's why you have to tailor make the time availability to what you have, and then the second or the review consultations can be for less time, so that you work around with what time availability you have, and then with the modes of management, you have to explain to them first, and then for that again, it's again your availability. If you have a psychologist or a physiotherapist working with you, because again with pain there are various types of clinics and availabilities, possibilities there. So then if you have them also in your team, you see, and then refer your patient to them and tell them it will take it, we will try these. You give them the options A, B, C, D, and tell based on the response, we will go from one to the other. That is how. And his question of whether getting annoyed, no, as time goes and as you see patients, you will be able to tell them. Initially, you may not have, and it requires a lot of various options you have to give. One size fits all doesn't work. Okay, because you have to look at it at the positive side, because if it was one size fits all, there's no job for all of us. Okay, the uniqueness is there because it is different, and you also have to tell them various options. All these you can try, these are the options, and then put that, I said smart goal, no, you should give simple, measurable, achievable target. Don't give a target which cannot be achieved and think that you're failing. So there are so many aspects and elements to it. So you also need not get upset, or the patient also need not be upset that they're not getting. So you have to be open in trying all options. So is that answering your query, doctor? Have I answered what you were
Yes,
looking
ma'am. Thank you,
for?
Radha ma'am. Yes, Smriti.
No worries.
Yes, Radha ma'am. Thank you.
Thank you. Go ahead. Like I think the rest of the questions in the chat box have all been covered, Dr. Khanna, I think, and you have given the link also for mostly, nearly all. We have covered everything. So if there is no other question, once again, a big thank you, Dr. Smriti Khanna, for being with us and taking the whole team through important things, and all the rest of the things which are there will be dealt in the next 2-3 sessions which we will be doing. In that case, I will hand it over to Sangeet.
Thank you. Thank you, Smriti Khanna, for the wonderful sessions. Thank you, Dr. Radha ma'am, for facilitating the sessions and clearing the doubts of the participants. Thank you all for joining the sessions. We will see you in the next sessions. Bye.
Thank you. Wishing you all good luck.